Hello everyone, my name is Anne-Marie Aguilar. The topic I'm presenting is on Capgras delusion, presented in neurodegenerative and psychiatric diseases as well as drug use. Capgras delusion, or CS, was once considered a rare occurrence and was only observed in psychiatric patients. Thus, early theories were of psychoanalytic origin. However, now CS is observed more often, including neurodegenerative diseases such as Alzheimer's, Parkinson's, and dementia with Lewy bodies. It is also observed in other physiological conditions such as epilepsy, pituitary tumor, and cerebrovascular disease. The psychiatric conditions where Capgras presents itself includes acute psychotic disorders, major depression, schizophrenia, and schizoaffective disorders. Exploring these conditions through multiple studies might help us to better understand the physical origins of Capgras syndrome. First, we take a look at psychiatric conditions presenting Capgras syndrome. A prevalence study by Salvatore and others showed that the disorder with the greatest risk for CS is for acute psychotic disorder followed by schizophrenia and major depression, then type 1 bipolar disorder and schizoaffective disorders with the lowest risk. The sample group of patients with CS shows a prevalence of 14.1% overall out of the original sample group of all patients that have experienced a psychotic episode for the first time. According to Phillips and David, misidentification syndrome is connected to dysfunction on the right hemisphere in schizophrenia and is more prevalent when synonymous with paranoia. The right hemisphere is said to be involved in holistic facial representation. This is in contrast to left hemisphere dysfunction seen in non-paranoid schizophrenics, where the left hemisphere is involved in processing letters. Schizophrenics experience misidentification syndromes that deal with recognizing people. Capgras is the most common, where it is theorized that the facial recognition pathways are disconnected from the limbic pathways, or specifically the amygdala. Another misidentification syndrome, known as the intermetamorphosis syndrome, is thought to involve the dysfunction of the fusiform face area that deals with face recognition. And a third one, called Figoli syndrome, is thought to be involved in disruption of the inferior temporal cortex, which is the final step of cortical visual pathways and deals with person identification. Others hypothesize that it is a disruption in the frontal cortex for a wrong decision of a person identification. Now we will look at CS presenting itself in patients with neurodegenerative disease. One study by Joseph compared differences of CS between neurodegenerative diseases and non-neurodegenerative diseases, and also among neurodegenerative diseases. Out of 47 subjects presenting with CS, 38 had a neurodegenerative disorder. Lewy body dementia was the most common and presented CS symptoms soon after onset of dementia. Parkinson's disease, in contrast, did not present symptoms of CS until an average of 8 years later, synonymously with the onset of dementia. Visual hallucinations were present with all cases of dementia. One proposed etiology of CS in dementia patients is the loss of dopaminergic transporters, similar to methamphetamine abuse. The idea of biochemical molecular mechanism is interesting to consider and discuss further later on. Morantz and Verghese discuss a case study of a 74-year-old man who is diagnosed for dementia with Lewy bodies, also presenting Parkinsonian signs. Lewy bodies are abnormal clusters of protein that accumulate inside nerve cells in Parkinson's disease and Lewy body dementia. This case study records the 74-year-old patient as having CS symptoms with the delusion of his wife being substituted by multiple different women. When the wife asked him what her name was, he responded with different names that were not hers, and even proposed marriage. His dementia worsened, and he was brought to a nursing home where his communication skills were minimal. At that point, his wife claimed that he seemed to recognize who she was. One case study has limitations in deciphering information in connection to CS with dementia. So Morantz and Verghese compare some other case studies. Another patient with Lewy body dementia and CS showed hypometabolism in the occipital areas when scanned by a PET imager. An autopsy later on finds plaques in the visual and occipital association cortices. Yet another case study had a patient with lacunar infarctions in the frontal and parietal white matter. In studies with Alzheimer's diseases, neuroimaging has shown links of right hemisphere disruption in the frontal and temporal areas of the face processing pathways. What all these studies have in common are physical disruptions that can be theorized to cause a disconnection along the facial recognition pathway and the limbic system. The ideas of disruption of biochemical mechanisms as the origin of CS was mentioned before in relation to methamphetamine abuse. An assistant professor of psychiatry at Yale School of Medicine discusses an individual case of a 26-year-old female grad student who volunteered herself to partake on a 4-day study. She is given active or placebo lorazepam followed by active or placebo ketamine. When given the active ketamine, she reports to feeling slightly anxious within 10 minutes. She returns to baseline after 15 minutes and reports that during the time on ketamine, she thought a different lab technician came in with the same clothes each time when in fact it was the same person. She also looked at herself in the mirror and had the odd sensation that the image was not hers. Ketamine is an antagonist of NMDA receptors but stimulates AMPA receptors and pairs both. According to a neurocomputational model of cortical hierarchies, NMDA receptor-based mechanisms mediate prior expectations while AMPA signaling mediates error in predictions. And pairing both brings about a sense of surprise and unfamiliarity. The assistant professor shares this case study to employ researchers for more empirical studies for underlying biochemical mechanisms as a source of CS symptoms. As you can see, these studies demonstrating organic causes of CS are in the beginning stages of uncovering the full picture. I imagine that all or most hypotheses presented in each study are correct, and the source of CS probably is caused by multiple factors. That is all, and thanks for listening.